You're muted, Purvi.
Good evening, everyone, and welcome to RSSDI Diabetes Bytes. As promised, every week we are here for you, bringing newer and newer topics related with diabetes, or sometimes, in the periphery, that are of public health importance. And we want to make you more and more aware of these so that you can lead a more fulfilled life. With that, let me just tell you about today's topic, which is diabetes in tuberculosis. Yes, many of you or some of you may have experienced this, but there is a huge population out there who doesn't pay attention to this or ignores the symptoms related with this. So let's get going. Let's understand more about this from two of our national and international experts, I should say, who have who have managed to spare time for RSSDI Diabetes Bytes. May I welcome Dr. Vishwanathan, sir? He is somebody with more than 30 years of experience and is a head and chief diabetologist at the MV Hospital for Diabetes and Professor M. Vishwanathan Diabetes Research Center at Chennai, and which is also the WHO Collaborating Center for Research, Education and Training in Diabetes. So with so many decades of experience, Sir is also the president of the DFoot International based in Belgium and consisting of experts from the world in diabetic foot disease. He has a PhD in diabetic neuropathy from Tamil Nadu Dr. MGR Medical University, also the recipient of the prestigious Vivian Fonseca Award from the American Diabetes Association for the research paper on diabetes and TB in 2013, is widely published, has hundreds of papers in different aspects of diabetes, and also is the honorary faculty in the Department of Podiatry Medicine in the Royal College of Physicians and Surgeons of Glasgow. What I need to add here is that Sir has been intricately involved with RSSDI for the past few years, and he was the vice president and now an executive committee member with RSSDI, and always taking the lead in not only its initiatives but also in various public health awareness programs. Thank you, sir, and welcome.
Thank you, Purvi.
We also have a very special guest with us, and let her, very simple demeanor not fool you. That is, welcome Dr. Sonal Sarkar. She is the professor of the Department of Preventive and Social Medicine at JIPMER, an institute of national importance in India, as we all know. She's received her medical training from Burla in Odisha, completing MBBS and then MD subsequently. Dr. Sarkar is also widely published in national as well as international peer-reviewed journals and has fostered research by serving as a member in various research committees of JIPMER and is a member of the Institutional Ethics Committee in SBVU. Her research interests are maternal and child health, care of the elderly, palliative care, as well as tuberculosis. Dr. Sarkar was instrumental in developing community-based cohorts of TB patients, almost 1,200 of them and their household contacts in the first phase of the Regional Prospective Observational Research in Tuberculosis, which is REPORT, in India in collaboration with the Boston Medical Center and Rutgers, New Jersey, USA. She has been involved in research on TB in pregnancy and is presently the India chair for the second phase of Report India. So today we are going to talk to you about this very, very important project, and we have these two distinguished guests with us. Welcome, ma'am, to the show.
Thank you very much, Dr. Purvi and Dr. Vijay Vishwanathan, for giving me this opportunity. It's my pleasure, honestly, to be here in this platform today. Am I audible, doctor?
Yes, ma'am. Yes, ma'am. For any physician today in India, I think tuberculosis and diabetes is very, very close to the heart. just cannot be ignored. Without much ado, may I hand over to Dr. Vishwanathan sir to take the proceeding further.
Yeah, thank you, Dr. Purvi. I think it's, first of all, I would like to thank RSSDI. RSSDI is one of the largest organizations of diabetic care professionals in Asia, consisting of number of people who work in the field of diabetes, and is one of the largest, and we are going to be the number one very soon. So this today we have a very important topic, and that is diabetes among TB patients. Always when I talk about diabetes among TB patients, people think that we are going to talk about TB among diabetic patients. No, today the entire focus is on diabetes in people who have tuberculosis. And we have a TB expert, Dr. Sonal Sarkar from JIPMER, and she's been introduced by Dr. Purvi. And therefore, I will go straight to the question. So, Dr. Sonali, why is tuberculosis such a dreadful problem, disorder, or disease in India and world over? We know that India, I'm talking about old statistics in 2015, that India is a home for 2.2 million people of the global number of 9.6 million people. So why is it very important to talk about TB?
Thank you, Dr. Vishwanathan, first for organizing this, and I congratulate RSSDI for this achievement in being the largest organization of this sort in Asia. Talking about tuberculosis and TB, first, as you rightly asked, why is TB so dreadful? TB is a dreaded disease because of the morbidity and mortality, the suffering it causes, and the deaths it causes in our country. So you rightly said the statistics, but it has increased a little bit. As of now, we have around a little more than 1/4 of the TB global burden of TB in India. Nearly 27 lakh TB patients are diagnosed every year, of which a little more than 4 lakhs die. A huge number of 4 lakhs deaths due to tuberculosis. And the immense suffering that it causes emaciation, cachexia. Earlier days, TB used to be called as consumption in English, and in Hindi it is called Akshay, because it causes slowly emaciation of the TB patients and causing a lot of suffering. The treatment we have as of now still is a long and difficult treatment. Why I say difficult is because the treatment consists of 4 drugs for the first 2 months, and then 3 drugs for the next 4 months. That is the least. If there is resistance or failure of this treatment, the treatment can go on for a longer duration, which may even become uh, 2 years. So a long duration of treatment with so many drugs. We know all the drugs, many of them cause so many side effects, and the disease itself is so debilitating. And then in addition to the treatment, and we are yet not very sure about whether every patient who is put on treatment will be cured. Many patients do not get cured. They fail the treatment, and many patients who are cured even again get relapse, causing immense suffering to not only the patient but also the family and the community and the society. And therefore people in general are dreadful of getting TB, so much so that there is a lot of stigma for TB in our society. People it's the diagnosis of TB is no worse than like diagnosis of HIV in our society. So that much of stigma is attached. So yeah, the morbidity, mortality, and the suffering the TB causes, and uh, all that make it a very dreadful disease. I hope I have answered your question, sir.
Yeah. So, since we are in a diabetes forum,
Hmm.
I'd like to refer to a study which Catherine Stevenson published in the BMC Public Health in 2007, where she said that about 20% of smear positive tuberculosis is attributable to diabetes in the year 2000. She published this paper in 2007. I think she died very soon after publishing the paper. So Catherine Stevenson, we remember, published that diabetes is a very important factor. Now, having said that, I think we had Anthony Harris, who was the head of the International Union Against TB and Lung Diseases. He wrote up a framework, collaborative framework on diabetes and TB in 2011. And this year, the WHO has written a collaborative framework on TB and comorbidities. So, diabetes is an integral part of the TB pandemic or endemic, epidemic, you can say. So, having said that, the government of India is determined to end TB by 2023. So, what are the steps the government of India is taking to end TB by 2023? We are only one year away from this target.
Yes, as you rightly mentioned in the beginning, TB is a huge burden in our country, and as I was saying, TB contributes to the India contributes to 1/4 of the global burden of TB. So unless we control TB, the world cannot control TB. And therefore, Government of India recognized the urgency to control TB in India and came forward this with this aim of trying to achieve TB elimination by 2025. So, the Government of India has taken a lot of steps in this direction. There are three sections in this. The first is the services for TB care in India. We all know that the TB treatment and diagnosis is totally provided free by the Government of India in all public sector hospitals. There is a nice infrastructure that has been developed by the National TB program in our country since it started in 1962, and then in 1990 RNTCP was started, and now we are in National TB Elimination Program. So the government is providing diagnosis, all the modalities, and all the treatment for TB cure to all citizens of India, totally free of cost. But the patients have to go to the public health facilities to avail these services. So the other important thing that government has tried to ensure is the completeness of treatment. As we were saying, the treatment is long, 6 months at the least. So many patients in between stop treatment or because of unavailability of drugs. So since RNTCP started, the government ensured a complete treatment box for each patient. As soon as the diagnosis is done, each patient will receive a box which includes all the drugs for the whole duration of treatment, so that in between there is no chance of drugs not being available or patient not being able to buy or any such factor coming in for the treatment completion not happening. So once the treatment is started, it is ensured that the treatment will be completed and the patient cured. The government in fact has taken up as a responsibility for seeing that every TB patient in the country is cured. So it is not, the responsibility is not on the TB patient or on the family for the diagnosis and cure. So once a patient has symptoms and reaches any health facility, be it a subcenter to PHC or CHC, the referral system will work, and the program will come in, and the diagnosis and treatment will be provided, and the cure ensured for that patient. So this is as far as the treatment is concerned. And then government is trying to also address other factors, and this socioeconomic determinants. We all know that TB is a disease of poverty. The most commonly affected people are those belonging to the lower socioeconomic strata of the society. Poor people with less access to good food, good healthy environment, often have the double burden of all these diseases, now even TB and diabetes. So to improve their diet and help TB patients take a better nutrition, the government has now started the direct benefit transfer, about providing 500 rupees to each patient, and the money goes to the patient's account so that the patient can buy a better healthy diet and get cured of TB. In addition to taking the drugs, the diet will help recover patient's health and help the drugs act better. So in addition to these two, the next component is the research in TB. Even though TB is a very, very old disease, we hardly know much about the disease pathogenesis. I mean, why the disease occurs, how it occurs, why are patients, how people get infected, but many of them do not progress to disease, and those who develop disease, why some of them will get cured and why some of them fail treatment. So to understand these disease pathogenesis and how the immune system works, and many other operational research related to tuberculosis, I mean, which interventions will work, which will help patients get cured faster and we reach more number of patients. So the government has two major research organizations, funding bodies in India. One is ICMR, Indian Council of Medical Research, and the other major funding agency is the Department of Biotechnology under the Ministry of Science and Technology. Uh, uh, they are now funding and supporting big research projects in India. ICMR has taken up a TB elimination campaign, projects in large states in the tribal areas to help early diagnosis and treatment of TB patients, through portable X-rays, and trying to reach all these services at the doorstep of those who have TB. And DBT has, as we are part of, yourself and me are part of the Report India network. So DBT started this in association with the NIH, National Institutes of Health in USA, and is providing funding to understand how we can better cure, or what can be done to understand TB disease better, and therefore come up with a better cure or prevention and control measures. So these are, almost the three-pronged approach the government is doing to help control TB in India.
Yeah, thank you, Dr. Sonali. I think it's very encouraging to hear that the government of India is acting so aggressively to end TB in India by 2023 or 2025 or whatever it may be. But coming back to diabetes again, so I think in this collaborative framework which Professor Anthony Harris, WHO have written, they have said you have to detect diabetes at a very early stage and treat it in people with TB. And one of the key drivers of TB in TB, one of the key drivers is diabetes is number one, HIV, alcohol, smoking, and undernutrition. In that order, in which the WHO framework 2022 says. Now, we showed that if you take a fasting blood sugar of more than 7 millimoles, which is about 126 milligrams, you have a specificity of 97% and an accuracy rate of nearly 92% in diagnosing diabetes. So it's very difficult to do a HbA1c in the program. Therefore, in the program, RNTCP program or TB prevention program, I think if you do a fasting blood sugar, I think we have shown in our paper in DRCP, Diabetes Research and Clinical Practice, in 2013, Dr. Satyavan, my colleague, showed that if you have a fasting blood sugar of more than 7 or 126, then you have an overall accuracy of diagnosing diabetes of about 92%. Now, diabetes is therefore a very important thing, because unless you cure diabetes, detect diabetes, and treat it properly, your TB sputum conversion might be delayed. We showed in a paper in 2013 that the TB conversion at the end of the intensive phase is in the TB diabetic population, the about 14.7% did not convert, vis-a-vis people who had only TB, no diabetes, 3.6%. And this was published in the Journal of Diabetes and its Complication and got me the Vivian Fonseca Award from the ADA. So I think if you have diabetes, the sputum conversion is delayed. And as Anthony Harris said, death rate might be more. Just like HIV is very difficult to diagnose because you don't get a apical TB as you get in non-diabetic cases. And you get more recurrence. So you get more recurrence, you get more death, sputum conversion is delayed. That's why it's very important to detect diabetes, treat it well. And Hardy Confield, my collaborator from the United States in the report India, showed in a paper that undernutrition, poor nutrition, low BMI was an important factor, was as important a factor as HbA1c. And this was published in Chest and uh, one of the big journals. So I think undernutrition is very important. So having talked about nutrition, before moving on to report, I would like to ask you, how do you improve the nutrition? You said 500 rupees the government of India is giving to have better nutrition. But as a TB expert, how would you, what sort of diet would you recommend to somebody who has diabetes? I'm sorry, TB. And when he has diabetes and when he doesn't have diabetes. Thank you.
Thank you, sir, for bringing this major point. Undernutrition is a major risk factor for TB, and undernutrition and TB are actually bidirectional. I mean, undernutrition causes TB, and TB also worsens nutritional status of individuals by causing cachexia, emaciation, and it's a very complicated, vicious relationship which goes on. TB treatment per se does help improve the nutritional status by improving individuals, the patients' appetite, and the patients are able to take a more and more food. And as they complete the first 2 months of treatment, intensive phase of TB treatment, it is seen that patients do recover some of the weight lost, but it is minimal and not adequate. So Dr. Anurag Bhargava, he is one of the pioneers in research on TB and nutrition in India. He is also instrumental in developing the document that the government of India, NTEP, has endorsed, a guidance document on nutritional care for TB patients in India. So his research has thrown light. The median weights of men and women TB patients in India is very, very low. I mean, they lose so much weight by the time the disease is diagnosed and the treatment is started. They're thoroughly emaciated, and so they need nutritional support, and nutritional support has shown to improve the outcome. I mean, his research shows that it improves the TB treatment outcome as well. So the requirement is of nutrition in TB patients is as much as a normal healthy individual. But what happens is, because the patients have lost a lot of weight, we ideally calculate their calorie requirement based on the desirable weight, not on the present weight. So if we say a normal adult, say of a 60-year-old, a 60 kg male, we would require about 2,400 kilocalories. That much would be required for a TB patient. But if the TB patient has lost, and his is the median, I mean, we've seen that the weights are about 40 kgs at the time of diagnosis. The patient would have lost nearly 20 kgs due to the disease. Then the calculation has to be done on the desired weight. So what we do is a rough, easy way of calculating the ideal weight for an individual is the height, because an adult would not lose height. So the height minus 100 is approximately the weight, desired weight for a normal adult individual. So based on that, we recommend about 40 kilocalorie per kg body weight of desirable weight per day. And that is the total calorie requirement. And the protein requirement also increases, because we all know that to fight a disease we need antibodies, though the cell mediated immunity is the more important immune system for TB, but antibodies do have a role. And because the patients are cachexic, to recover they need more of protein. So an adult individual, usually we need 1 gram per kg body weight per day, but an TB patient would require about 1.2 to 1.5 grams of protein per kg body weight per day. And in addition, to increase the calorie, because the patients may not have a good appetite because of the disease, it is recommended to increase the calorie with a little more of fat intake, like oils. And the protein can come from pulses if the people are vegetarian. But if patients are agreeable to non-vegetarian diet, eggs definitely would be a better source of protein. Eggs and pulses, and if people can take fish or meat, any of these protein sources would be good. And in addition, milk. So milk will provide both calories, fat, and so this would be milk products and protein and fat and total calories. We should see that it is matching the patient's need. And ideally, it is recommended that the patient takes 3 major meals and 3 snacks. I think that is, you would be a better person to advise. I mean, how the calorie should be split. But in TB, we say it is 3 snacks divided between the 3 major meals, and that should take care of, so that one meal is not very heavy, and so that the blood glucose doesn't go up suddenly. And the snacks, so small divided meals are also recommended for diabetics, and so also for TB patients, so they would not be able to take too much at one time, so it is split up, and that would help if they are diabetic as well. So it's not more of cereals that is recommended for TB patients. So rice and all that, they need not increase. So an increase in calories may come from fat, which I think is less troublesome for a diabetic, and protein. And therefore this diabetic TB patients can always take the additional extra calories and protein they need, meeting their calorie requirement also.
Yeah, I think your suggestion is very good. But in people with diabetes, when the fear is when you take more carbohydrates, your uh, diabetes will not get controlled and so on. So
Mhm.
today, if you're a non-vegetarian, egg white is a very good source. If you are a
Mhm.
non-vegetarian and don't mind taking eggs, 2 eggs a day. But today we have in India a number of
Mhm.
companies which are making protein supplements which you
Mhm.
can take in between meals.
Mhm.
Now you can,
Mhm.
it's available commercially or you can make it yourself. So I
Mhm.
think protein shakes are available. People
Mhm.
make protein shakes on their own at home.
Mhm.
You can
Mhm.
take it between meals, so which
Mhm.
will not upset your diabetes control. So the point is well taken what you said.
And
Three
hey,
meals.
sorry to interrupt. I forgot one more point. It is the micronutrient need of these patients. So it is also recommended if they can add some multivitamins, because if the diet is not adequate to provide the micronutrient requirement of all the vitamins and minerals. Sorry, sir. Please go
I
ahead.
know we have another 10 minutes left. So there is one question in the chat box to you. When should we pick up cases in the diabetic scenario with regards to adding medication, person on active ATT treatment or after
Mhm.
completion? I'm not
Mhm.
able to understand the question. But
Yeah.
when should we pick up cases? So maybe you can answer it.
Yes, that's a good question. Actually, we suggest picking up cases at the time of diagnosis itself. In our studies in Report India, we saw about 35, 38% of TB patients had self-reported diabetes. So, what we are trying to do is screening, the bidirectional screening. Uh, we have initiated screening for diabetes in TB patients at the time of diagnosis. So now routinely in the program, the TB patients are screened for HIV and diabetes. And but we are also proposing, the government also recommends, and this screening for TB in diabetic um, patients. So that also screening for four symptoms like cough, fever, weight loss, and night sweats is being done at the time of diagnosis. And for every visit, this 4S symptom screening is done for all diabetes. So this bidirectional screening, and it is best to pick up at the time of diagnosis, both TB in diabetes and diabetes in TB, because as sir was telling, the prognosis for the disease progression is poor if TB patients have diabetes, and so vice versa. It affects diabetes also affects TB cure, and TB affects diabetic cure. I mean management control. So both ways, it should be best at the time of diagnosis as early as possible. And we are trying to actually screen now in the community, screen for active screening for TB, and thereby simultaneously they should get screened for diabetes and get diagnosed for both at the earliest. I hope that answers the question, sir.
Perfectly. Now, moving on to report, I think we should talk a little about report
Mm-hmm.
because it's been on for 6 years. So,
Mm-hmm.
report India, RER is a big R, E is a small e, and PORT. It stands for Regional Observational Prospective Study in TB. It is a bilateral, multi organizational collaboration initiative by the Government of United States and Government of India under the Indo-US VAP Vaccine Action Program. It started about 5 years ago and it's still going on. And I'm very happy to tell you that Dr. Sonali is the Indian chair of this Report India. There's also Report Africa, South Africa, Report Brazil, and so on. For Report India, Dr. Sonali is the chair. And can you tell us a little more about Report and what we achieved by Report in the last 5 years? And it's a sixth year which is going.
Yes. Thank you again for bringing in a report. So, as I was telling, the understanding about TB disease is not adequate even now. We have a huge burden of TB infection in the country. I mean, almost estimated to be 40%. 40% of the India's population is infected with TB. That means we have the TB germ in our body. It is somewhere in our lungs, has multiplied, has a focus, but is not flared into a full-fledged disease. Uh, these people have a lifetime risk of getting TB disease about 10%. So of those infected, 10% would at any time in their life would get the disease. But we do not have the understanding about who gets the disease and why they get the disease. As you were saying earlier, sir, I mean, we know the diabetes, malnutrition, and alcohol, smoking, these increase the risk. But what protects the others? Not everybody gets disease because of these. So what protects those who do not get disease? And among those who get the disease, not everybody is fully cured. Some of them at the end of 6 months of treatment are found to be uh, failed, who have failed treatment. I mean, they're still excreting the TB bacilli in their sputa, and therefore they have to go on to again a long tedious process of treatment. Some of them develop resistance to the drugs that they are taking, so they have to be put on a longer regimen and longer duration of treatment with more number of drugs. So with all this complicated disease, our understanding, we are trying to identify some markers, some chemicals in our body and some genes in our body which can predict which infected individual will develop the disease, say in the next 1 year, 2 year, 3 years, 5 years, who is going to develop disease. If we know this, we have treatment for preventive treatment for those who have infection, so we can treat them aggressively, and then they won't get the disease, so infection is cured. And if we know who is going to fail treatment, who is not going to respond to the treatment, will not improve, will not get cured. So if we know at the beginning, at the time of diagnosis, we can always put them on no a longer regimen, better regimen at the start, so that the patient's suffering is reduced. And so we are trying to identify markers. We have succeeded to some extent. We have identified some proteins, we call those omics, so some metabolomics, proteomics, lipidomics. So we have identified some chemicals, to speak in general terms, which can predict who is going to not respond to the treatment, or which infected individual is going to develop disease. So with genes and chemicals we can uh, now predict. And we have also, in the second phase, in the 6th year, we have now started a group of people, we call them diagnostic cohort. So those who are symptomatic, have symptoms of TB, not all of them test to be positive. Almost 5 to 15%, we roughly say 10% of those who are having TB symptoms, like cough, fever, weight loss, and night sweats, will be diagnosed with TB. So in them now we are also trying to test some of the diagnostic tools that we have already developed, the genetic markers, the transcriptional markers, we say. So whether the genes, if we test, and then those tests can be done using blood. You don't have to ask the patients to cough out sputum, which is not always very convenient. So from blood, a prick of a drop of blood, those tests can be done. So those tests we are doing now. And also we have started vaccine trial. So TB, we know the vaccine. We do not have a good vaccine, though BCG is given to everybody. The coverage is almost universal in our country for BCG vaccine, but the vaccine is not very effective. It hardly protects only the pediatric age group, that too from severe forms of TB. So what we are trying to now do is test newer vaccines, which would may prevent disease or prevent recurrence. So those trials are also going on, and we hope to get some results soon. So and epidemiologically also, the TB research and report has thrown light on the major risk factors, like you were saying, the study Hardy Confeld did on malnutrition and alcohol and all other risk factors. What proportion of the TB diseases in India is attributed to which risk factor? Like we came to know that in our study, about 60% of the TB among males is due to alcohol. And as you were saying, 20% is due to diabetes. So these are the important results that we have got, and is contributing to policy making for TB control in our country.
Thank you for bringing this point. I think Report India, along with Serum Institute, is working on a phase 3 trial with VPM 1002, which is
Yes.
a vaccine which might be coming out very soon
Mhm.
and which prevents recurrence.
Hmm.
So, Report India is involved in that along with Serum Institute in Pune, and we are trying to develop a vaccine which is in late phase 3 trial. And I think it will be a good boon for patients who had TB once to prevent a recurrence. Now, I will switch gears to uh, metformin, because this is a diabetology forum. So, metformin, Amit Singhal from Singapore first showed in 2014 that it's an anti-TB drug. And there were several studies after Amit Singhal, including one from NIRT. Now, what the NIRT ICER, which is a part of NIRT, Subhash Babu and Pavan Kumar, showed that certain MMPs, like MMP7, is
Hmm.
lower in people who take metformin. So, metformin is a wonder drug, and when you want to use metformin, people are a little scared because people have already lost weight. So insulin is definitely there, going to be there. But after they put on weight, you should probably consider metformin as an add-on. And metformin will not reduce weight drastically because people are on insulin and you have controlled your diet and nutrition is improved. And autophagy mechanism is one, reducing the superoxide dismutase levels is another. And Amit Singhal showed that the growth of Mycobacterium tuberculosis is reduced in an AMPK dependent manner. AMPK is monophosphate protein kinase. So metformin is a wonder drug, and please do not hesitate to give it in people. You give insulin, you control diabetes, but please do not avoid metformin because metformin has been shown to have anti-inflammatory drugs, anti-inflammatory action. Again, Pawan Kumar and Subhash Babu showed that in diabetes and TB and diabetes, the inflammatory response lasts for nearly 18 months. That is, you give TB treatment for 9 months, dots therapy, and so on. But the inflammatory response in TB with diabetes lasts for, this is part of report India, it lasts, the inflammatory reaction lasts for nearly 18 months. So metformin will reduce inflammation. Dr. Padma Priya's study showed that it does not prevent recurrence, but it can reduce inflammation in the NIRT study. So metformin is definitely useful. Please do not avoid metformin in people with TB just because they've lost weight. When they've gained weight, you should definitely use it. So we'll be concluding another 2-3 minutes, Dr. Sonali. And uh, I think going into the chat box again, I don't see. Yeah, so uh, you are very confident of ending TB by the various three routes you said the government of India is taking, and we are sure Report India in phase 2 also will work towards eradication of TB. So, would you like to say any final word about TB and how to eradicate, how to get this dreadful disease from our country, Dr.
Yeah,
Sonali?
thank you so much. Thank you so much. So we can fight TB and control TB only we if we work together. I mean, we have to reduce stigma, and we saw in our study that most well-to-do people were actually hesitant to accept the diagnosis, and there was delay in initiation of treatment. So there is a stigma, and people do not accept TB easily. So let us be aware it is a treatable disease. So the symptoms, people should be aware of the symptoms. Cough for more than 2 weeks with any of the other symptoms or any one. I mean, only cough for more than 2 weeks. Suspect it may be TB. Go to your relatives, friends, anybody we come across. We should encourage testing for TB. We can control TB only by treating TB because TB is an infectious disease. We have many people around us who are roaming around with
Yeah, so she was giving a message that TB, don't fear TB, but diagnose TB mm, and diagnose diabetes among TB patients. Do not fear it. It is treatable. And people like Report India are doing a lot of research, trying to find out new chemicals, as she said, to diagnose TB. Like you can't bring out sputum. Some patients say, I don't have sputum. And Dr. Sonali said there are chemicals being tried, nano drop being tried. There are so many new technologies which are being tried by Report India too. So I think there is light at the end of the tunnel. And Dr. Sonali, thank you very much for showing us that there is a light at the end of the tunnel. And once you have TB, it's not that you have certain death, not anymore. You have good food and good drugs. And even if you're a person with diabetes, don't worry. So, would you like to end with your message, which got cut off? Would you like to end with what you were saying?
Oh, is it telling me?
Yeah, because you got cut off. Yeah,
Oh, really? No, I was here, sir. I just said.
yeah, but
I mean, yeah, that's what. So my final message would be that let us all work towards controlling TB. It cannot be done by the government alone. As individual, as the society, we have responsibility. Many NGOs are coming forward to support TB patients. A lot of work is going on, but everyone has to put in their bit to control TB. So let's fight together. That is the slogan, and that is where we will reach by 2025 to end TB.
so I'd like to thank RSSDI and Dr. Purvi Chawla for another good edition of RSSDI Bytes today. And today we had a very good discussion on a very important problem on TB and trying to diagnose diabetes among people with TB. So thank you, Dr. Purvi, and thank you, RSSDI, for taking up this very important subject. On to you.
Thank you so much.
Sir and ma'am, I haven't left my chair at all. I've been listening to everything that you both discussed today, and let me compliment both of you that besides all the field work that you both are so invested in, it was an extremely insightful discussion today on diabetes and TB and the medical as well as the social impact it has. So, even as a diabetologist, I have learned so much. And I think, as any physician working in India today, even if they are not in this field directly, it is extremely important for them to understand because both of these conditions are so both of these the infection as well as the condition so highly prevalent in India that none of us can escape this. So we really need to understand this, and if if our project has to be successful, we all have to be recruited at the grassroots level and do our bit and contribute to get rid of TB by 2025. Excellent work, and thank you once again from our president, Dr. Brijmakar sir, from our secretary, Dr. Sanjay Agarwal sir, and the entire executive committee. I must say thank you, sir, for proposing this topic and introducing us to Dr. Sonali ma'am as well. And the effort that you both took to, talk to our audience today. So once again, a big, big thank you from the social media team of RSSDI.
Thank you so much.
Thank you. My pleasure.